Okay, welcome. This is the last session of the day before the reception. Thank you for sticking around. So today, this is the first time we hold a literature review session. And there is a background on why we decided to do that. Part of the CBA, the Cord Blood Association, is always to keep our members updated on the latest events and manuscript and science, state of art about cord blood in general. So we thought that expanding this to the conference would have been a good opportunity for all of us to be updated. We also decided to do that in terms of to see whether or not we can predict something that is going to affect the field of cord blood in the future. So in the future, we're going to monitor what we presented today, whether or not has had an impact in the field of cord blood, not only cord blood transplant. So I need to start with this. That's very important to me because the state of art and review session that we were doing on the Cord Blood Association website was led by me and Al Broxmeyer. Al was remembered today in a beautiful session, but I do need to tell all of you that actually Al was one of my mentors along with Colleen. I was part of the TRTH class of 2010, and you can say that I'm here. Oh my gosh, my beard is all black, but look much younger. It was many years ago. And Al really was a mentor throughout my career. Actually, I do have a similar story of what has been shared today, because Al invited me to Indiana. He tried to recruit me to Indiana. I did not go, but he kept following me for the rest of my career. I really owe him a huge thank for what he has done. For me. About that visit in Indiana, you saw this picture today. The first thing that he showed me when we got there was exactly the recipient that he used for transporting the first cord blood transplant. I want to tell you one thing. It's the only time in my life that I go and give a talk in another university and I have the person inviting me showing up at the airport and picking me up. Al did that for me. We went to Indiana University, and I think he left his lights on because the battery went completely dead. So we got rescued. It was February, and I'm not used to the Midwest things. You know, the Pacific Coast, it's much warmer than the Midwest in the winter. So it was a great experience. I really had great experience with Al, and that is my tribute to him. So. Today we're going to present different papers. I had the difficult exercise of presenting something about regenerative medicine, so that's not my field. Please bear with me. And I did pick two papers, and then Leland Metheny and Yanni Politicos will present other paper more related to cord blood transplant. The first one that I choose is this one on the use of umbilical cord blood and cord blood tissue-derived cell therapies for neonatal morbidities. I chose this one because the idea behind all these clinical trials that have been done is to target lungs, brain, and heart, but with different mechanisms. For the lung, the idea is that cord blood cells can reduce the inflammatory cytokines to be pro-angiogenic, secrete regenerative factors, so they can be used in lung injuries like, for example, bronchopulmonary dysplasia. In the brain, instead, same thing, reduce inflammatory process or reduce apoptosis. So being used for patients, infants with hypoxemic encephalopathy at birth. In the heart, instead, it's a different story, because what we are looking for are cells that actually can regenerate and could be pro-angiogenic and secrete regenerative growth factors. So this Australian group did a very good exercise of looking at all the published cord blood trials for infants and neonates. And after a big search in the PubMed and through the registry, also in Australia and in New Zealand, they found 12 published clinical trials. And of these 12 published clinical trials, I want to point out a couple of things. First thing is that of these 12, only one is a phase 2 randomized controlled trial. All the other ones are all open label, dose escalation trial, but with no matched control. The population of these clinical trials in general are either, as I say, bronchopulmonary dysplasia or hypoxemic encephalopathy or cardiac birth defects at birth. I found very interesting also the way the cells were giving, because we had a variety of ways the cord blood were giving. Intravenous, that's one of the common ones, but for bronchopulmonary dysplasia, intratracheal administration or intrathecal, or in some cases directly intraventricular according to the type of the clinical trial for a specific disease. As you can see in the last column of this table, pretty much all clinical trials were aiming to safety, except for the only phase 2 randomized study, which was looking for death or moderate severe bronchopulmonary dysplasia as a primary outcome. The exercise that they did was, again, very interesting to me because clearly showed that we have very little literature in this field, only 12 published, with 24 registered trials. So there might be other 12 that will come out soon. As you can see here, in a quarter of them were used for bronchopulmonary dysplasia. Hypoxemic ischemic encephalopathy was 33% of this clinical trial, 60% for the preterm morbidity, and congenital heart disease 8%, and 16% for hydrocephalus. On the right side, you can see instead the way what type of cord blood they use was mononuclear cells, autologous cord blood mononuclear cells in the majority of these trials, or allogeneic cord blood cells, or mesenchymal stem cells derived from cord blood, or the entire cord blood in other cases. At the end of it, the story, all the phase 1 studies showed safety of this approach with no GVHD that was found for this patient. And specifically to the phase 2 randomized study, I found very interesting that actually they compared 33 cord blood patients receiving cord blood mesenchymal stem cells to 33 patients receiving placebo controls, and they show only an improvement in reduction in severe BDP in extremely preterm infants. That led me to the second paper that I decided to present today, and it's been published very recently, not even a month ago, and about the application of cord blood mesenchymal stromal cells in children with multi-drug resistant nephrotic syndrome. I picked this paper for one reason, because it was very interesting to me that actually cord blood extends its application to renal diseases. And the other thing is because it comes from Middle East, so I kind of was biased on that. No, that's not true. I think it was a good paper. So just to give you a little bit of background, the idiopathic nephrotic syndrome is the most common glomerular disease in children. And I didn't know it when I read it, but about 15% of children are resistant to the initial treatment with steroids. And of these 15%, the majority of them fail a second line of immune suppressive therapy and end up with end-stage renal disease and eventually with the kidney transplant. And because of the disease, actually, they have the tendency of relapsing even after the kidney transplant. So this group in Italy, they decided to include in this study patients who failed to achieve remission with at least 2 immune suppressive attempts. They use cord blood mesenchymal stem cells. They were manufactured starting from whole cord blood, cultured for 24 days, and harvested day 17 and day 14. And they were then cryopreserved if the purity of the mesenchymal stem cells was over 90%. Then they decided to give the mesenchymal cells at day 0, 14, and 21 at the dose of 1.5 million per kilogram of the patient. Of course, the primary outcome was safety and toxicity, and the response to therapy was evaluated 12 months after the infusion. You can see here the characteristic of the patients. They enrolled 11 patients. Of these 11 patients, the median value of proteinuria was 8, and at least 3 were the lines that the patients received before being enrolled on this clinical trial. You can see on this table instead the majority of patients, they were on some type of immune suppressive therapy, steroids, cyclosporin, steroid, and MMF at the moment of the treatment. So the main finding of this study, they ended up actually that 2 patients were excluded after being treated because finally they could identify a genetic mutation for this patient. So when there is a genetic mutation for protein for this type of disease, they would not respond to any type of therapy. So therefore, they eliminated these 2 patients, and they were left over with 9 patients. They found that 3 patients were considered responders, and 6 patients were actually considered as non-responders. When they compare these 2 groups of patients, they see actually significant reduction of proteinuria in the patients who were the responder ones compared to the non-responders. They also did a bunch of correlative studies. And one of the things that I found very interesting is that they looked at cytokines. They were not did not see any difference in terms of reduction or increase of cytokines after giving the mesenchymal cell cells, but they did see that in the patients who responded, and you can see here in this red line here, the 3 patients actually, they did have an increase in the total of Tregs in the bloodstream after treatment, speculating a role of this mesenchymal cell stimulated a Treg response, so acting as an immune suppressant agent. So they're now planning, based on this positive result, they're planning a phase 2 randomized study with other immune suppressive therapy, and we'll see where this leads. So my experience, I'm not an expert in regenerative medicine. I don't know if Joanne is in the audience, because she's definitely better than me to talk about this topic. But what I got reading this paper is that definitely cord blood and cord blood-derived cell therapies are an attractive prospect in regenerative medicine. There is no questions about it, because they're easy to access. There is low immunogenicity. None of these studies showed any risk of GVHD, and that's a very well-established collection process and storage process. The things that made me think, though, is that the timing and the dosing, it's very unclear, and based on that, I think there is still a long way to go. Then I think that was my last slide, and I'm gonna, who is the next one after me? I think is Leland, right? So we're going to take questions at the end of the session. I would like to introduce Leland, who is an assistant professor at the University Hospital in Cleveland. And I also would like to say to you that both Leland Metheny and Yanis Politicos, they are the chairs of the special interest group of cord blood for the ACTCT. Thank you, Leland.
Okay. Thank you, Filippo, for the opportunity to present today. And I'm going to be speaking on expanded cord blood in non-malignant diseases. I'm going to go over a patient vignette, which started kind of my interest in this, what we know about cord blood transplant in non-malignant conditions, and what we know about expanded cord blood in the non-malignant conditions of aplastic anemia and sickle cell disease. And then I'll briefly revisit the patient vignette and have some insights for you. So we have a patient that presented to us who is 46-year-old. He's of Southeast Asian descent. He's married and has 1 young child, and he's a cardiothoracic nurse at our institution. And he has a history of aplastic anemia 20 years ago. And that was treated with ATG at an institution which resulted in his remission. He presented to an emergency room with thrombocytopenia, which rapidly developed to pancytopenia. And then he was initiated on triplet therapy, which resulted in improvement of his neutropenia, but not improvement in his anemia or thrombocytopenia. His donors included 1 8 out of 8 HLA matched donor, that was international or non-domestic, a haploidentical donor that for various reasons was not an acceptable donor, and he had a good number of small mismatched cords. So what do we know about cord blood transplant and aplastic anemia? Not a ton in a 46-year-old. We do know from small studies, one perspective in pediatric patients and AYA, that the cell dose is important. So a dose of 4 times 10 to the 7th TNC needs to be in combination with a single or double cord needs to be the goal. In pediatrics, that's the same goal, although there is evidence to suggest that if you go higher, you can have better outcomes. HLA matching appears to be important from retrospective analyses, and 8 out of 8 or 7 out of 8 cords have similar 5-year overall survival, and that comes from a paper out of the CIBMTR by Merritt Apin. Conditioning is important. We tend not to do myeloablative chemotherapy because the aplastic anemia has already ablated their marrow. So Flu/Cy, TBI, and ATG are often utilized in this context. And when we do all those things correctly, outcomes appear to be good. There was a small prospective study out of France that showed a 2-year overall survival of 85%, and there was a retrospective analysis that I already mentioned, which combined non-malignant conditions and peds, which showed that a 5-year overall survival was around 80%. So what do we know about cord blood that's expanded in sickle cell or severe aplastic anemia? I'm getting ahead of myself. So there's an ongoing clinical trial at the NIH led by Dr. Childs that includes patients up to the age of 55. They have to have failed immunosuppressive therapy. Then they have to have an adequate graft source for Amadubicel, which includes the characteristics below. They can't have donor-specific antibodies, and the conditioning is the Flu/Cy TBI. So 8 out of 8 patients have been enrolled in this clinical protocol. There's been some publications at ASH in abstract form. The first 3 patients combined a haplo-Amadubicel combination graft source, and when they found no graft failure, they proceeded to single cord blood, expanded cord blood units. The expanded cord blood units contained a median of 75 times 10 to the 5th CD34 cells, which is quite excellent for a cord blood transplant, and that it meant a 42-fold expansion. The HLA matching was not exact. In fact, none were fully matched, and the median was 5 out of 8. And 7 out of 8 patients are alive without evidence of GVHD, chronic GVHD, and are off immunosuppression. So a small trial, not yet complete, but encouraging results. The engraftment was actually quite excellent, with neutrophil and platelet engraftment at 10 and 31 days respectively. And you can see in the graphs below that T-cell immune reconstitution was sufficient, and that antibody production was sufficient fairly early on in the transplant course. A detour, I know we're not necessarily talking about aplastic anemia in this context, but another non-malignant condition that we sometimes encounter in adults and are encountered often in pediatric transplant is a sickle cell disease. There has been published information out of our colleagues at Duke on results utilizing expanded cord blood in this setting. So there's a phase 1/2 trial that was completed in patients with severe sickle cell disease up to the age of 45 with no matched or related or unrelated donors that could go under 2 types of conditioning regimens. The second one was preferred in this clinical trial. So 13 patients were enrolled, 10 with double cord blood transplants, 1 in expanded Amadubicel, and then an unmanipulated cord blood, and 3 patients with Amadubicel alone, which were not necessarily part of the double cord analysis, but they did report the results of those. So the majority of patients received conditioning regimen B, which was the myeloablative conditioning regimen, and the median CD34 dose was a whopping 12 times 10 to the 6th, which we usually don't see at 10 to the 6th for cord blood, but there it is, which resulted in a 79-fold expansion. The mismatches in these patients in respect to the cord blood were quite large. In fact, there was one that was a 2 out of 8. But 92% had a 4 out of 6 HLA match for the expanded cord, and about 70% had a 4 out of 6 for the unexpanded cord. So with a follow-up of 4 years, the event-free survival in the double cord blood cohort was 85%, which is quite excellent. There was a high degree of GVHD in that context, most likely due to the high degree of HLA mismatch. But at 14 months, our median of 14 months, there was no GVHD symptoms and discontinuation of immunosuppressive therapy in all of the 11 surviving patients. Of the 13 patients who received the double cord, 1 had secondary engraftment failure and 1 had death due to GVHD. In the 3 patients that received a single expanded cord blood, 2 engrafted fully, 1 experienced secondary engraftment failure and was rescued with autologous cells, and all 3 are alive. The median neutrophil and platelet engraftment was 7 and 61 days, and you can see from the slide below, or the figure below, that immune reconstitution in T cell, B cell, and NK cell was appropriate. So returning to our story, a little bit more information. So the MUD was actually not truly matched as 10 out of 12, but the mismatches were permissive. The donor got COVID, so that delayed the donor. And the donor just got medically cleared, but when I was writing this, they didn't. And the patient still has yet to be transplanted. The initial recurrence of the aplastic anemia was in 2021, a year ago. So insights, in aplastic anemia and sickle cell disease, it seems to be that with expanded products, that cell dose is more important than HLA match. And overall survival outcomes appear to be favorable, even in these small clinical trials. Robust and early engraftment can be achieved, as well as immune reconstitution with expanded cord blood units in non-malignant conditions. And hopefully, in the future, we can utilize these products to bring patients to transplant quicker, unlike our patient now. And it may be useful as well for the cord blood community to do an analysis of the inventory and see how these cord blood expanded technologies can expand the domestic cord blood inventory to our patients. Thank you.
Thank you. Thank you, Leland, and it's my pleasure to introduce Dr. Yanni Politikos from Memorial Sloan Kettering Center.
Thank you, Filippo. Let's see my slides. Oh, can I go back? There. Thank you, Filippo, for the introduction, and thank you for the opportunity to present in this session. In my talk, I'm going to focus on the application of cord blood transplantation for high-risk hematologic malignancies. I will start by reviewing a recent paper which I think is very important, and Filippo, I think, gave a spoiler during an earlier session. And then in the second, this will serve as a segue to get into the potential mechanisms of GVL in the second half of the talk. These are my disclosures. So the paper that I selected to present is entitled Cord Blood CD8 T-cell expansion following granulocyte transfusions eradicates refractory leukemia, which was recently published in Blood Advances by the group at Royal Manchester Children's Hospital. This is a case series of 5 pediatric patients aged 1 to 7 years with relapsed or refractory acute leukemia, primarily AML, who underwent single-unit cord blood transplantation. These patients, as expected based on their age and probably their ancestry, they had fairly well-matched grafts and fairly high TNC and CD34 cell doses. However, these patients had concurrent infections at the time of transplantation, primarily fungal, and therefore they received serial infusions of third-party pooled irradiated granulocyte products that were obtained from the NHS blood bank service. Each granulocyte unit contained, on average, 1 × 10⁻⁻⁻ neutrophils, but also it contained a relatively high number of monocytes and lymphocytes. The investigators made the somewhat coincidental observation that in these patients, as shown in those representative patient charts, there was an early surge of ALC fairly early before engraftment. And upon further phenotyping, those lymphocytes were found to be CD3 T cells and primarily CD8s, although there was a smaller CD4 surge as well. When looking collectively at the entire patient cohort, the investigators calculated that from the infused T cell content with the cord blood graft, by days 7 to 9 post cord blood transplant, there was a 21 to 123rd-fold peak T cell expansion. What was also notable was that this expansion was very rapid, and it was transient with rapid return of the T cell counts to normal range. And it was CD8 biased, as evidenced by the higher absolute CD8 T cell count compared to the CD4 T cell count. And this is in marked contrast to the CD4 and CD8 recovery that is noted in the green highlighted area in control patients who did not receive granulocytes. The investigators went on to further characterize those expanding T cells. They observed that they express activation markers, including HLA-DR and CD38. Also, notably, they acquire a memory phenotype. Almost 100% of those cells had memory phenotype, which is in marked contrast to the primarily naive phenotype of T cells that are contained in the cord blood graft, but also in the T cells that are recovering early post-transplant in patients who undergo CBT without granulocytes. In addition, those expanding T cells express CD107A at a high proportion, both in comparison to a control, but also in comparison to a patient that did not receive granulocytes and underwent standard CBT, suggesting that those expanding T cells have cytotoxic function. And while I'm not showing it here, the paper proves that those expanding T cells have diverse repertoire, suggesting polyclonal expansion. So how did these patients do? They all engrafted relatively early, at a median of 14 days. They all got pre-engraftment syndrome, which was characterized by early onset and high severity, both by clinical characteristics and by inflammation markers. But PS was responsive to steroids, and they all were able to stop immunosuppression very early without subsequent development of graft versus host disease. And what was very impressive was that despite their high risk features, with the exception of an early TRM death, 4 out of 5 of those patients are alive and disease-free 14 to 40 months out from their transplant. So the investigators conclude that naive cord blood-derived CD8 T cells undergo expansion and activation in response to granulocytes, and those T cells, despite being transient, are able to eradicate leukemia. They also go on to provide a tentative mechanism, which consists of allogeneic TCR signals from the antigen-presenting cells in the third-party product that stimulates T helper cells that then lead to priming of CD8 T cells by expression of MHC1 molecules, and this may be potentiated further by the bystander effect of the neutrophils. The final event is here the activation of those cytotoxic CD8 T cells that can eliminate leukemia cells by targeting leukemia antigens or minor histocompatibility antigens. So why did I like this paper so much to present it? I think despite this being a sort of a coincidental finding, it provides a simple strategy that could be explored further in high-risk patients. And the group in Manchester is actually pursuing a clinical trial with correlatives built in to probe the biology further. It also further builds upon the group's previous work that has shown that cord blood-derived T cells have enhanced anti-tumor effects and unique CD4 biased T cell reconstitution, and also it provides a hint towards the GVL mechanism. So in the second part of my presentation, I will quickly review what has been known before this publication in terms of the GVL in cord blood. Several retrospective studies, which I do not have time to show here, have suggested reduced relapse risk in CBT series compared to adult donor transplants, and a potential benefit of cord blood in MRD-positive patients. However, and it is also, as a general observation, true that reduced relapse risk has been most commonly observed after double unit CBT. However, the potential mechanisms are not well established. So when thinking about the potential mechanisms, in my view, those can be categorized in 5 groups. 1, the unique immune properties of the cord blood-derived T cells. 2, the unique pattern of immune reconstitution after cord blood. 3 is the HLA immunobiology and the presence of mismatch in most cord blood grafts. Related to number 3 is the HLA loss, or I should say the lack thereof, in cord blood, which I will show you later on. And finally, point number 5 is the graft versus graft interactions that happen in the setting of double unit transplant. And I will very briefly highlight some key publications supporting each one of those in the next few slides. Starting with the unique immune properties of cord blood-derived T cells, I think it is well established that cord blood T cells are naive, they have high proliferative potential, and the group from Manchester actually in an earlier work showed in an EBV-driven lymphoma mouse model that compared to adult peripheral blood T cells, cord blood T cells, when infused into mice inoculated with EBV lymphoma, they are able to eradicate tumor more efficiently, and they lead to better survival of the mice. And they have done very elegant work in the paper, and they attribute that to superior TC1, TH1 anti-tumor effects. We also know that immune reconstitution after cord blood, when there is no or at least low exposure of ATG, is CD4 biased, and Jaap Bollens in multiple publications and his group in multiple publications have shown that not only does that help with the lower transplant-related mortality, but in AML patients it also reduces the risk of relapse. So this may have something to do with the GVL after cord blood. Looking at the HLA mismatch in cord blood transplant, as a general observation, with increasing degrees of HLA mismatch, both in pediatric and adult populations, this is only one example from the Japanese registry study, there are lower rates of relapse, but also there are higher rates of GVHD. Now, whether the lower relapse risk is related to the GVHD or those are independent is not well established, but I think we would all agree that there is discordance between the HLA mismatch and the degree of and the GVHD severity after cord blood. And in fact, there may be some benefit to mild to moderate graft versus host disease after cord blood. Very quickly, I'm going to mention the HLA loss story. This is a slide borrowed by Luca Vago that was shown at the previous meeting of the cord blood SIG, and it's outdated, but the principle here is that when assessing relapse samples by stem cell source, looking at genetic HLA loss, among 49 recipients of cord blood, there were no cases of HLA loss. And the investigators hypothesized that this is because the mismatches in cord blood happen in trans, whereas in the whole haplotype is transplanted. and therefore there is no benefit to the leukemia cell to knock down the mismatched HLA. I will finish my talk with what I think is very exciting in terms of the biology. It's the double cord blood platform and how the graft versus graft interactions can lower the risk of relapse. It's well established now for the last decade that the double graft is associated with lower relapse risk, and that was also corroborated in the European randomized single versus double trial in the ATG-free arm, and also in patients with MRD that had benefit when they received a double graft. But whether this is only related to the associated increased risk of GVHD or if it's independent is not clear. However, an elegant paper that hints that maybe the graft versus graft interactions may actually potentiate the GVL is this work from the University of Rotterdam, where the investigators showed that when the losing unit is matched to the patient and the leukemia cells at class 2 alleles, and those are both mismatched to the winning unit, they lead to potentiation of the GVL. So in a way, the losing unit serves as a vaccine. So I'm finishing my talk by putting up the slide again that I showed earlier, now with some of the key references highlighted, and I'm trying to bring the granulocyte story here and see how would that fit and how does it change previous knowledge. I think one could say that the robust expansion that was observed in the work by the University of Manchester, or should say the Manchester Children's Hospital, is that the unique properties of cord blood may lead to the robust expansion, but also I think we have to make a comment about the graft versus graft alloreactivity, and that also goes back to what Filippo presented at the previous session, where even though that was a single unit transplant along with a third-party product, there were still interactions between the unit and the product. And if we better understand how each of those mechanisms and how the third-party product or the presence of the losing unit potentiates the GVL, we may be able to get to the design of novel platforms where a third-party product that may be cheaper than a second unit may lead to reproducible enhanced GVL. With that, I will thank you, and I look forward to a productive discussion.
Great, thank you. Before opening the session for a question, I want to thank both of you. I think it was a good session in terms of highlighting different aspects of use cord blood, with and trying to summarize in terms of regenerative medicine. Definitely, we have many trials. Safety is primary outcome for many of them. There's a lot of interest in that field. Then we heard from Leland, and in my opinion, one of the messages to take home for everyone is that still cord blood doesn't get considered all the time. And then we learned from Yanni that that there is so much that we still need to learn about cord blood transplant. It's fascinating why we have so low rate of relapse and all what he explained. So I want to just to start with that. Cohen?
So one comment to Yannis, and one, it shows how little we know and how much when we do more trials, we should really study correlates and study them very well so that we understand better, because it's all a bit mythical right now, right? We keep saying that there's more GVL, but we don't understand. And as a note to that, our memory is short. 5 years ago, there were a lot of talks here about inherited paternal antigens by some and direction of HLA reactivity against inherited paternal antigens, for which we need to know the mother of the cord. And that's clearly a mechanism that's also active, and actually is also active in haploidentical transplant. So that's something to be remembered.
I absolutely agree. And the other thing that I didn't have the time to mention is that in terms of the HLA mismatch and how this may play into the reduction of relapse risk, there is emerging data both in cord blood but also in the haploidentical and mismatched unrelated donor field that the locus of the mismatch may matter, with class 2 mismatches maybe conferring some protection against the relapse. So the immunogenetics of and how those lead to reduction of relapse risk, I think, is very fascinating, but not very well understood topic yet. And I do agree that correlatives would be important in any future trial.
Thank you. Mitch.
Thanks for a fun session. This is interesting. Yanni, so that first paper, the transient T-cell expansion, it's enticing to think that maybe this is prompting and priming cord blood-derived T-cells, improving GVL. But I wonder if it could be that this is simply expanding some residual radiation or chemotherapy resistant host T-cells that get activated and then die off, and perhaps maybe not a GVL augmentation, or maybe even an autologous, perhaps even, maybe the autologous T cells could go after the tumor and help. I don't know, but it doesn't look like they did early chimerism, which would have been interesting to see.
I think in the results, they only describe that those were donor-derived, but I don't think that the chimerism data is presented in detail. It's a very good point. What you just said actually may apply to the concept of the microtransplants, where the presence of some product stimulates some immune response, even if it's coming from the host-derived cells.
Yeah. And I think the burst, it is so unusual to see, Mitch. I think it goes beyond the milieu created by the radiation or the chemotherapy.
Well, you would think if it's donor-derived that it wouldn't be so transient, is my thought.
Yeah, but I think the rejection, might be contributing to the fact that it's transient. Because at the end of the day, the immune system, even if they are transplant patients, I think they still get rejected and they lose their effect. But speculating.
Yeah.
I do have a question for you, Leland. And it's about, how do you see cord blood in the field of benign hematology? We're not going to call them anymore non-hematological disease, but benign. Where do you think cord blood can fit, and whether or not expansion should be considered? It seems a very good landscape for expansion. What is your thought?
The current landscape is it's not considered. So that's the current landscape, and hopefully the future landscape is in those patients who don't have matched related or unrelated donors. I hope we can utilize expanded cord blood products because they seem to confer quite excellent overall survival, even in those small populations. But people have to consider them first of all and do them well. That's the thing. So you have to build an expertise, and we also have to have the tools to do them.
Yeah, because personally, I do think that, if you want really a perfect scenario, because this morning, Colleen mentioned about the feasibility of something that we need to keep in consideration. That is definitely where you would like to get some patients engrafting very rapidly and dealing with less infection and complications. So it does seem a perfect scenario, but still doesn't happen. So we need to ask ourselves whether or not we have a possibility of changing it, or instead the fact that, in all honesty, matched and related do fantastic for aplastic anemia. The results are outstanding, and also the upload data coming from Johns Hopkins are very good. So that needs to be taken in consideration.
But not everyone has those options, so that's the thing.
Yeah.
If I knew about the NIH trial, I would have referred the patient to the NIH.
Good. Any other question? If none, I'll spare 2 minutes, and I would like to thank all of you for participating to this first literature review session, and I'll invite all of you to the gathering at 6:15. Is that correct, Karen? Good, perfect.